Critical care from NRI Medical College, Bangalore. So currently he is working as consultant critical care at Geetham Institute of Medical Sciences and Research. So I invite him to talk on small change, big gains, tubes and transmission. Over to you, Dr. Neeraj.
Small change, big gains, tubes and transmission. The main topic, the crux of the topic is that generally every day we send a lot of investigations, repeated investigations mainly in critical ill patients. And these investigations, how much they are costing on your blood loss and anemia and the requirement of blood transfusion is going to be the crux of the topic. So coming to the introduction, the blood loss with diagnostic testing of little of no clinical significance in most of the hospitalized patients, but it's not the same in critically ill patients because generally they require multiple times of blood testing to be done every day. And it's a modified risk factor mainly for the iatrogenic anemia. Okay, and to minimize exposure of these already very sick patients to additional risk associated with blood transfusions. So iatrogenic anemia is what we are inducing because of these diagnostic blood loss. So iatrogenic anemia, the development of anemia due to medical procedures is a universal concern among critically ill patients. Or you can here the iatrogenic anemia is caused due to diagnostic blood loss. So the adult intensive care unit patients lose approximately 340 to 660 ml of blood per week due to diagnostic testing. That comes to around 1 to 2 units of RBCs during a single admission or maybe more. And a study alone by one herself on diagnostic blood loss was 17% of the estimated total blood loss with a range of 12 to 21% in different subgroups in a study of population medical intensive care unit. So that's heavy. And estimation of mean daily blood loss in hospitalized patients range from approximately 12 ml per day in wards, and it's around 40 to 50 ml per day in ICU. So Salisbury et al. Estimated that for every 50 ml of blood collected during hospitalization, the risk of developing hospital-acquired anemia has increased by around 20%. So the main culprit here is, I'm not saying that we are sending too many investigations leading to blood loss, but I'm saying here is we are sending large amount of blood for blood sampling that is causing this hospital-acquired anemia or iatrogenic anemia. That's the point we are going to address here. So the collection of larger than necessary amount of blood samples for laboratory testing that can be minimized, and also using of small tubes in patients who are admitted in ICU obviously will have a better outcome and better effect on iatrogenic anemia. Over time, what has recently in the past we used to have the laboratory equipment was too old and it requires around 3 to 5 ml to give you an investigation output. But over a period of time, laboratory equipment has advanced so far that it's hardly requiring 0.25 to 0.5 ml to give you a report. Okay, but we are sending 3 ml to 4 ml. The EDTA tubes require 4 ml and the sodium citrate tubes require 3 ml for CTC or RFT or LFT. And around 80 to 90% of it is being wasted. Few days back I visited our biochemistry laboratory just to check on it. There I observed that we are getting around we are sending a daily around 3 ml for the EDTA tubes, suppose. And what they are requiring for their machine is hardly 0.25 ml. They put in the small Hitachi tubes that is taken to the machine. That 0.25 ml is also the dead space blood because that 0.25 ml is required for the machine to sense it, to just sensitize it and aspirate the blood. So that's the minimal amount of blood that is required for an investigation. But still we are sending around 3 ml to 4 ml of blood every day. So the hospitalized patients, hospital laboratories collect around 8.5 times more blood than required for a complete blood count report, and also 12 times more blood required for the metabolic report. A study of 57 hospitals found that patients hospitalized for more than 15 days had a higher risk of requiring transfusions because of cumulative phlebotomy volume from blood drawn throughout their hospital stay. So this was coming to the evidences, this was a systemic analysis which was done around it included main topics were how to prevent iatrogenic anemia. What are the interventions that can be done to prevent this iatrogenic anemia? They have checked on multiple interventions. There are 5 total interventions they have checked on. That is using small blood volume tubes, and closed blood sampling devices, point of care testing, staff guidance, and bundle interventions. Bundle interventions include combination of 2 or more interventions. So here, what they have checked with each intervention is how much this intervention had led to the blood loss, to prevent the amount of blood loss, or prevent the amount of incidence of hypergenic anemia, or requirement of blood transfusion. For each intervention, they have checked these three parameters. So coming to the first parameter, that is a closed blood sampling devices. In these closed blood sampling devices, it's like all arterial lines with a closed loops, and we can re-inject the blood which is not required for our sampling or testing. So, and they have checked that the impact on blood loss, impact on hemoglobin, and transfusion risk, which I have discussed. So there was a very minimal effect on requirement of transfusion or hemoglobin effect, but there was a significant effect on the blood loss. Reduction of volume in blood loss, there was a significant effect on reduction of volume in blood loss, which will be seen. And coming to point of care testing, in one study, transfusion within the first 14 of admission decreased 46% after implementing of point of care testing. Generally, this point of care testing was done in NICU or pediatric patients, but the main crux was the evidence was insufficient to determine the impact of point of care testing in any of the outcome. So then the bundle interventions, they have combined 2 or 3 investigations, either the small tubes or the point of care testing. They have combined these interventions and used in the form of bundle intervention. There are 3 studies that conducted these bundle interventions. In adult ICU, found that blood loss among patients in the intervention groups at least 65% less than that among the control groups. And the absolute reduction ranged from 10 ml per day to 20 to 29 ml per day. That was the significant amount of blood loss that has been decreased with the intervention of bundle interventions. Then coming to the small volume tubes. The small volume collection tubes and that has shown a major change in the decrease in the blood loss. This is the standard blood tube, generally of 3 to 4 ml, which we have discussed, and generally that is 0.5 ml blood is only required for investigation. Rest of it is scattered, which I have discussed previously. But what is a small volume tube is that it is designed to draw approximately 50 ml less blood than the standard volume tubes by using less vacuum strength. And they are the same physical dimensions and collection technique as standard volume tubes and are compatible to standard laboratory equipment. So they have checked, there are a few studies which checked the small volume tubes whether they could decrease the blood loss or not. And this was one study, impact of blood loss on minimizing diagnostic blood loss in the critically ill patients. They could identify, they have checked whether conventional tubes and the small volume tubes, whether they had any impact on blood loss. They found that the conventional tubes and small volume tubes has a significant decrease in the blood loss. And also the use of small volume tubes decreased the amount of blood drawn from the patients, and also that led to decreased significant amount of blood loss when using small volume tubes. And the other study which has a reduction of blood loss from laboratory testing in hospitalized patients using these small volume tubes, again they have checked whether there is decreased blood loss and also whether this small volume tubes has caused inadequacy of the blood sample. They could identify that there was significantly decrease in blood loss and there was no inadequacy of blood sample that is required for the investigation. And this other study which was published in 2020, they have looked into this similar component of reducing blood loss. Again, in patients who are in the all over hospital and also the patients who are admitted in transplant and critical care units. They could identify that in the transplant and critical care units, diagnostic blood loss was significantly lower in all over the hospitalized patients, but the maintenance of mean hemoglobin was much better in transplant and critical care units. So this is the latest evidence, that is the STRATUS trial. This was published in 2023 in JAMA. This study was done in Canada from a period of 2019 to 2021. Which included around 20,000 patients, 10,000 each into each group. The main objective was to determine whether previously all the other studies which I have discussed were about the decrease in the amount of blood loss. What this study has checked into is the requirement of blood PRBC transfusion. Okay, reduces PRBC transfusion without compromising laboratory testing procedures. Whether small volume tubes had any impact on it. So it was done in around 25 ICUs, included around 30,000 patients. The primary outcome was number of RBC units transfused was patient during ICU admission, and secondary outcome proportion of patient receiving at least one RBC transfusion, decrease in adjusted hemoglobin concentration during the ICU stay, length of stay in ICU and hospital, and mortality in ICU. So the main thing is the RBC transfused, number of units RBC transfused per their mean ICU stay did not have any significant effect. There was no much significant decrease in RBC stay when all the patient cohort has been included. But in a secondary analysis, when they included the patients who had an ICU stay more than 48 hours, there was a significant decrease in the requirement of blood transfusion, requirement of RBC units. That was the primary outcome, and in the secondary outcome, there was no much significance in either the mortality or the hospital stay or the mean ICU stay, etc. So this was which was discussed, and so the conclusion of this study is the transition from standard volume to small volume tubes for blood collection ICU may reduce RBC transfusion without impacting biospecimen's efficiency for laboratory analysis. That was the conclusion of the Stratus trial. So take home message here is the effects of transition to small volume tubes on RBC transfusion hemoglobin were modest at the individual hospital level. So we could not completely say that patients they are requiring RBC transfusion for sure, but they had a large impact on the blood loss of the patient to prevent the blood loss of the patients. And in the Stratus study alone, 30% of the studied ICU patients received about 36,000 RBC transfusions in less than 2 years. And the use of small volume tubes may have saved approximately 1500 RBCs all over. Okay? Yes. So the main intake is, even there was no much big evidence of saving the RBC units, but if you implement it, it is of more likelihood of benefit than harm. So our take is to go ahead with the small volume tubes and preserve blood. Thank you.
Thank you, Dr. Neeraj. That was a very insightful talk on to use small volume tubes and also go to a laboratory and check how much blood is actually being utilized. So now I invite all three speakers to be on the stage for questions.
Complex concentrating trauma patients.
So, see, prothrombin complex again is a factors, okay, which is we supplement. So the problem is expensive, and if I have an alternative and the ratio which I need, okay, if I have a massive transfusion protocol, even much before I talk about the 10 units, in the first 3 units also I will try to supplement with 1:1:1. So in here to fix it, the prothrombin complex will be difficult. But if I don't have any factors available and I know my factors are deficit, I can supplement. Prothrombin complex has been more commonly used in factor deficiency isolated, where I replace them, and I used in patients where the newer anticoagulants were used, like direct thrombin inhibitors and other, where I don't have access to the antidotes. See, in those patients, I use prothrombin complex. In trauma victim resuscitation, it will be expensive. I will probably prefer FFPs over that. Prothrombin complex factor 7A are not in standard format to erase.
Sir, is there any absolute contraindication for injection tranexamic acid?
Yeah. So, ma'am, tranexamic acid, I think came up. We used to, all of us used to use tranexamic acid for pregnant ladies with PPH, and also those who had a hematuria or somebody is losing badly after neurosurgical procedures. But we always thought about antifibrinolytic agents leading to more thrombotic complications. That's what always was in our mind. So, in trauma, or in active bleeded patients in peri-surgical areas, if you really wanted to exactly know whether I have a problem with platelets or clotting factor or antifibrinolytic agent, the fibrinolysis is not holding on. The moment your clot form, it is getting dissolved. If I have a TEG or a ROTAM, I can probably specify where I can use. I use platelets, FFPs, or I can use a tranexamic acid. But how many centers TEG is available? How many centers can do a TEG and access to it? So what we do is, assuming a massive transfusion patients will have some amount of fibrinolytic problem, empirically tranexamic acid has been used. That is the beginning. But later, as we saw, CRASH 1, 2 and all the trials, which suggested there is a significant mortality benefit of 28 days, one after the other, is now we have become a standard of care in them. The last year's PAX trial didn't show any significant mortality benefit, but in the meanwhile, it has no side effects. That is answers your question. If you ask me if a patient had a stent or some stroke or some deep vein thrombosis or something, do they have any contraindications to use a tranexamic acid? It's not. The mechanism is different, antifibrinolytic mechanism is different. I'm not making them pro-coagulant.
But what sense is the timing is important in trauma patient?
Yeah, probably the timing which they are talking about is a gram loading followed by a gram in 8 hours infusion at this point of time. And we use it very commonly in PPH patients who actually bleed to death. So early PPH patients are shown to be effectively helpful.
Yeah, my question to Dr. Neeraj. Your topic, it opens the insight into small tubes. And the recent update, 2024 April, they have given the prophylactic transfusion of blood to prevent the blood loss in ICU patients. So you are working in the GSMR. So how many bedded ICU? 16 bedded ICU. Are you going to implement prophylactic transfusion of the blood in your ICU patient, or you are going to change the big tubes to small tubes?
Obviously, the known risk factors with transfusion, there could be multiple risk factors with blood transfusion, either allergic or overload states. So I would prefer not going ahead with prophylactic blood transfusions rather than simple mechanical change of going ahead with change of small tubes. But that can be more beneficial than transfusing.
Is it economical?
Much more economical.
So you have to convince your laboratory medicine directors to use the
small tubes.
Right. Thank you.
Sir, my question to Dr. Pasha.
Yes.
Sir, your study is a comparative study between the endovascular thrombectomy and medical.
Yeah.
What medical management, sir?
All the work is standard medical care.
Like-
what we are doing, thrombolysis and the support anticoagulants and all that.
And any comment regarding the sovatilitide, which is being recently being used in most of the cerebral infarcts?
Yes, with the permission of Chair, just I want to request NR Medical College, which is a second annual critical care program. It's a PG assembly and an exam-oriented program. Lot of stalwarts from the nationwide we are having there. So I request all our delegates to endure. Thank you.
First page they have to project.
Yes.
So, okay, you want to comment?
Yes. Thrombolysis actually, maybe you might be having checklist. Basically, thrombolysis followed by thrombectomy, not to see any things like. But ultimately, selection of patient is very important. M1, M2 level, and basically, what our policy is, as soon as the patient comes within the window period, we do a CT, the angiogram. And from there we go with the thrombolysis and followed by thrombectomy.
So what Leslie ma'am is asking about is you did a thrombolysis, you didn't achieve the target. You could not recanalize the vessel, the impact remained to be the same. You still are in that zone, grey zone of actually recanalizing them. So if you recanalize them taking wheeling down to a thrombectomy, what is the outcome? Is there any see, even before thrombolysis, thrombectomy ma'am, only with thrombolysis, patients show improvement and we see a good percentage of them do bleed. It's not uncommon. So this need to be explained to the family. These are all not just a magic therapies which don't have any other problems, they do bleed because brain is a fragility, so compared to your heart and lungs where you do. Ma'am, thrombectomy, the problem is you have to select appropriate patient who actually failed at thrombolysis and still continues to have the infarct there and the symptoms there. If you see a large vessel occlusion somewhere in M2 segment of middle cerebral artery or downstream, where you can open and your core and penumbra, the ratio, this all actually is a decision of individual patient. If you don't take it carefully, if you're already in the zone, already crossing the penumbra to ischemia to infarct, you just open, you will be devastatingly bleeding there badly. So again, relooking at the penumbra zone, the zone of core, the ratio which our interventional radiologists do, and it's very standard of care as Dr. Jason was said in the cities, in a tertiary care, if thrombolysis fails, thrombectomy or interventional radiologists will be on board. But they deny 50% of cases, they say no, these patients are not suitable for any thrombectomy, this vessel looks very distal or to a smaller, and few of their times say this is not suitable because there is already infarct. So you are not going to make any difference, it will further worsen. So it is all individual decision, but in spite of all this, you may still feel, and unfortunate that your first two cases had.
Actually, the reported incidence is 0.9%, and we had 100%. So I was like a little skeptical.
Can I share my experience of neuro ICU with post-thrombectomy? So post-thrombectomy, the problem is actually even post-thrombolysis followed by thrombectomy, the issue will be like how good is the technique of thrombectomy? If it is a single passage or multiple passages, or how much amount of blood loss has happened during the process, and invariably these large vessel occlusions post-thrombectomy, they will land up with an early decompressive craniectomy. If we are delaying the decompressive craniectomy because of the cerebral edema, they are not going to have good mortality benefits. So all these large vessel occlusions with the thrombectomy, they land up finally with decompressive craniectomy. I think that is something we should be more proactive, not stopping just at the level of thrombectomy. Venkat sir.
Yeah, Venkat.
So our experience is they finally land up with decompressive craniectomy rather than just stopping at the edge of just thrombectomy, because the aspects are significantly low and you have large infarcts.
No, we don't know, but I think like not all patients of thrombectomy goes to decompressive craniectomy.
Especially large vessel occlusions.
Rajesh, sorry to interrupt you. Sorry, sir. But we have to stop.